Thank you to Sages for letting me present. So my talk is about whether there is a role for training residents in the robot. I have nothing to disclose. So first, I wanted to take an audience poll. Who has surgery residents at their institutions? Raise your hand. Okay. Who allows residents to operate on the console? Excellent. And who thinks that residents should be trained on the robot? Pretty good. And who has a robotic training curriculum for their residents? Yes. So I think our audience is pretty representative of what's going on across the country. At this point, there is no doubt that there is an expansion of robotic platform in general surgery. And general surgeons, according to the marketing division at Vinci, general surgeons are the most common surgeons completing the clinical pathway to credentialing. And as there's more demand for robotic general surgery cases, there's also a more demand for robotically trained general surgeons. So how does this translate to general surgery residents? In 2002, there was a study done that showed there's 11% of general surgery residency programs that use robotics. But a study done that was in 2015 showed that there has now been 96% of general surgery residents who have access to the robot. That is a significant increase. The study was done as a survey that was sent out to residents across the country. And 63% of those residents indicated that they participated in robotic surgery, and 60% of them has never had any training or prior education before their first case. I think that's pretty telling and pretty shocking statistics. So what are the residents doing in these robotic cases? And I think the audience can also agree on this, that most residents are really just doing some observation and participating at the bedside and not necessarily on the console. And this is true for both junior residents as well as senior residents. So what do residents think about the role of robotics and what their role is in the operating room? About 65% thought that training in robotics is important during their general surgery residency, and about half of them thought that the robot actually interfered with their training because majority of the time they are only at the bedside and not really getting to do any of the operation. And this was especially true for senior residents. And 80% of them wish that there was some kind of formal training on the robot. So despite this interest and this desire for some kind of curriculum, there are actually very few curriculums out there and few institutions that have some form of a formal training. In the same survey, about over half of residents said that they have had no training whatsoever. About 20% of them said that they had some robotic simulation training, and there are very few who actually had some hands-on training or any kind of formal didactics in robotics. There are many challenges to training residents, and I think we can all appreciate these. First, there is limited seasoned and experienced robotic surgeons anywhere, and as a result, if the attendings are not comfortable and not proficient on the robot just yet, it is very unlikely that they would hand over the reins to a resident. It is very time-consuming, especially for less seasoned attendings. A general case that usually takes 45 minutes now takes 2 or 3 hours with the incorporation of the robot, especially in the beginning, and it's very taxing to then say, let me increase that by another half an hour, 1 hour, so that the residents can try on the robot as well. There is limited hands-on teaching during live surgery. The robotic surgery is designed so that there's just one attending or one surgeon operating at a time. Obviously, it's expensive for animal model robotic training, and there's limited learning time with duty hour regulations, and also in, I think, surgery curriculums all over the U.S., it is already packed with skills lab, with didactics and time in the operating room that it's hard to incorporate robotic surgery in there. And it really needs to be incorporated as parallel learning at the same time as open procedures, basic laparoscopic skills, and robotic skills. So I think robotic surgery is here to stay, especially given, I think, what everyone has seen today, especially in the last 2 or 3 years, it's become very evident. So the question really is not if we should be training residents in robotic surgery, but rather how we should be training them. And there's right now no official guidelines for robotic training. Now I'm going to talk a little bit about what robotic curriculum should look like. Luckily, there are double consults, and if you have a double consult at your institution, it would be ideal. And because it's significant, I think it does increase the safety for patients, as senior surgeons are able to control the robot during a session where the residents are doing a portion of the case. Simulators are great, and it is a good way to allow residents to practice on the robot. It's cheap, it's simple, and it's safe prior to them participating in a live case. And the curriculums should really involve a combination of observation, simulation, dry labs, maybe some wet labs if the funding is there, some bedside assistance, and then eventually console, being a console surgeon. Not only is there no formal curriculum out there, but there's also really no certification that residents can get for proving that they have completed robotics training. Vinci had come up with this certificate for requirement, which essentially involves having residents complete an online course, as well as hands-on bedside maneuvering of the robot. Its requirement is 10 cases as a patient side assist and 20 cases as the primary surgeon on the console. But obviously, we would like to create a curriculum that's outside of the industry suggestions, and University of Alabama in Birmingham has really done a great job and is really the model for most robotic training programs across the country. And what they've included is robotic training starting from just PGY1 all the way to PGY5. And it's a gradual responsibility in the OR after completing the online course and also the didactics and simulation. So essentially, as you can see from this, even from PGY1, residents start doing the online training and attending a Saturday course about robotics. And then as a PGY2 and 3, they're already starting to do portions of an uncomplicated lap chole. And it progresses on to more complex cases by the time they're PGY5. There are various successful robotic training programs already in the country. Here's just a few, and I'm sure as we see from the audience, it's essentially been incorporated in many different institutions already. Penn State has one, Louisiana State, and Greenville, as well as Medical University of South Carolina. These are just ones that have sort of published or discussed their results. And SAGES Robotic Task Force has a SAGES Master's program in robotics that's underway as well. Robotic training has now been incorporated into MIS fellowship, and more institutions are working on this. At Emory, they have a curriculum that's very similar to what the Da Vinci has Intuitive has suggested, except they added another criteria, which is at least 5 cases that are recorded and reviewed by a general surgery faculty that does robotics. And right now, they've already graduated 6 MIS fellows. So in conclusion, I think it's pretty obvious at this point that robotic surgery is here to stay, and it is pretty mandatory for us to provide some kind of robotic surgery training for general surgery residents. They need to be prepared when they graduate, if and when they use robotic surgery in their future career, in whatever case it is that they, at that time, that they will be doing. And the goal really is to have a robotic training that can be instituted without sacrificing the operative time or the surgical outcome or the cost. And there are already curriculums out there, and it just needs to be disseminated and implemented at more institutions. And that's it. Thank you.